Yes, 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 doctor.
Amazing. Thank you so much. So, so to start with, my name is Hesham Ibrahim. I'm one of the emergency medicine consultants in Hampshire hospitals in United Kingdom. And today I've been given the task to try to cover shock in less than 50 minutes. So I'll try to do my best, but that would be a big challenge because shock is a massive topic. So what I will try to do during the next half an hour to 50 minutes is to cover some pathophysiology of the shock to get some more deeper understanding of how shock happens and what happens exactly there. So we can have a general approach about how to handle shock when those patients present undifferentiated. So plan is a bit of chat about the shock itself. Then at the end, we're going to cover a couple of cases so we can apply what we've talked about during the day. So let's have a bit of an overview about shock first before we move on. The first question to be asked is, do you really think that it is important to talk about shock now? Is it important to know about shock? If you're not really sure about the answer to this question yet, all what I'm going to say is I've been following the talks of the symposium since yesterday, and I don't really think that there was one single talk that the word shock has not been mentioned in. So this is how important shock is. Shock is a very common presentation in ED. You cannot really practice emergency medicine without really mastering how to handle shocked patients. Sorry, can I just ask for everyone to be...
قلت لك اجي اخرجهم مش نبدا بعد هذا.
Okay, so let's move on. So shock is the final common pathway before cardiac arrest generally. So every cardiac arrest patient that you're going to see probably have been through some sort of a shock before arriving to you and reaching the cardiac arrest state. And if you do not treat shock, then the next step is going to be multi-organ failure, then death. But the good news is it is a reversible condition. So if you can detect it early enough and you start treating it appropriately, then you can reverse it back. So to start with, let's start with the definition of shock and see what shock means. Shock is basically a circulatory phenomena. It is a failure in the circulatory system. It is an abnormality in the circulatory system that results in an inadequate organ perfusion and tissue oxygenation. So you've got a failure in the circulation resulted in inadequate perfusion to the organs and loss of tissue oxygenation. And this in turn will result in failure of the aerobic metabolism and the start of anaerobic respiration at cellular level. And this will result in lactic acid production. And then this will progress to cause cell death and multi-organ dysfunction. How to recognize the shocked patient? It might sound like a silly question, but actually this is a really hard question to answer. Shock actually may not that easy to spot all time. And sometimes to diagnose a case of shock, it is not always that simple because there is no single vital sign or lab test on its own that can definitely diagnose shock for you. So for example, shock can present typically with hypotension and decreased cardiac output, but in some types of shock, the blood pressure will be normal and the cardiac output may even be high, and it is still a shock state. So this is the hard bit about diagnosing and spotting the shocked patients. So shock can be broadly divided into two big groups. The first group is shock with an impaired cardiac output. So the heart itself is not pumping enough blood peripherally. Or it can be with an impaired systemic vascular resistance. So the heart is pumping enough blood, but actually because there is a significant vasodilation, the whole circulation is just pulled peripherally away from the heart. Those ones with an impaired cardiac output can be because of either decreased preload, so the venous return to the heart is decreased, or decreased myocardial contractility. There is a good preload, there is a good venous return, but the heart is unable to push hard, or actually the heart is doing the best, but there is a significant resistance afterwards. There is an increased afterload that is causing this shock. Regarding this one, where the other one with the impaired systemic vascular resistance, actually the severe vasodilatation is the reason for the significant reduction in the afterload. And that's why those patients are shocked. So let's give it some examples to make it more understandable. The examples of shock with impaired cardiac output. First one, as we said, the first reason is decrease the preload. This can happen with hypovolemic shocks, whether you've lost blood, like what happens in trauma patients, for example, or you've lost fluids, like the patients with diarrhea and vomiting or patients with burn. So with those ones, you get the shock secondary to hypovolemia, secondary to decreased the preload. The second cause is decreased myocardial contractility, which can happen in cardiogenic shock, like what happened with massive MIs, for example. And the third cause is the increased afterload, which can happen with the obstructive shocks, like massive pulmonary embolism or tension pneumothorax or cardiac tamponade. So as a general rule, shock patients with impaired cardiac output, they are usually called peripherally due to the cutaneous vasoconstriction. So just bear that in mind as an important clue for your shock patients. The other group is the shock with an impaired systemic vascular resistance, the severely vasodilated patients. And we call this type of shock the distributive shocks. The first example to this is sepsis. So septic shock patients are severely vasodilated in association with severe infection. And the anaphylactic shock, where they are severely vasodilated secondary to a massive histamine release, or the neurogenic shock when they're vasodilated because of a loss of a sympathetic tone. So these are the three examples of the distributive shock. And again, as a general rule, shock patients with impaired systemic vascular resistance, they're usually presenting with warm peripheries due to the cutaneous vasodilatation. So that is another important clue that you can use to differentiate the type of shock. Okay, so commonly affected organs are, and those are the organs that you're going to focus on in your clinical assessment. So skin is an important organ here. The skin is usually cold, but it can be warm, as we said, and it will be sweaty. Kidneys, usually with shock, there will be a renal shutdown. And if the urine output is less than 0.5 ml per kg per hour, be worried. This is a bad sign. Next is the heart. So the circulation, as we said, you can have hypotension with tachycardia, but this is not an absolute thing. You can have shock without this, and you might get chest pain with your patients if they hypoperfuse the coronaries. And lastly, the CNS, the brain. Those patients can present with disturbed conscious levels secondary to the circulatory failure. How about the shock index? So shock index is an important term, an important tool that you need to know about because it will help you a lot diagnosing shock patients. Basically, you need to divide the heart rate by the systolic blood pressure. So you're not using the heart rate only, you're not using the systolic blood pressure, or you're using both together. So let's assume that your patient has got a heart rate of 70 per minute and a systolic pressure of 110. If you divide them by each other, you will get 0.6. Your shock index is 0.6. Normal is from 0.5 to 0.7, so you're fine here. What if the heart rate goes up, like what happens with shock, and the blood pressure goes down? This total number will go up, and this is bad. So let's assume that your patient's heart rate now is 100, divided by a systolic pressure of 100. If you imagine this patient, 100 of heart rate is not that bad, not that worrying. Systolic pressure of 100, again, not that bad. It is not ideal, but it's not too bad. But if you put them over each other to get the shock index is going to be 1. 1 is a bad shock index. Anything above 0.8 is bad. So actually, this is far more sensitive to spot shock rather than isolated vital signs. So that's the whole point. This is a very useful tool to understand the tachycardia within the context of blood pressure. And it's shown to be more sensitive than vital signs alone in diagnosing occult shock. And as I said, a shock index above 0.8 is bad. So let's move on to some pitfalls in diagnosis of shock. So relying solely on the systolic blood pressure as an indicator of shock, this can delay the recognition of shock because it can take a long time for the blood pressure to go down. And it might be just before the cardiac arrest when you get the significant drop in the blood pressure. So waiting for this to happen is not a good idea. Never underestimate the shock index. Take it seriously because it will give you better sensitivity in diagnosing and spotting those patients. And tachycardia and skin vasoconstriction are the earliest measurable circulatory signs of shock. So I always say this to my junior colleagues. Always feel the hands and the feet of your unwell patients. You will spot a lot just by doing this. And lastly, never underestimate sweaty patients. So as a general rule in emergency medicine, sweating in ED is bad. I've never come across a sweaty patient in the emergency department and it was a benign thing at the end. So it will be a heart attack, it will be an MI, it will be sepsis, it will be shock, it will be thyroid storm, it will be something bad. I know I work in United Kingdom and the weather here is a bit cold, but even in Egypt, I worked there for years and sweating in ED is bad. So I always say, if your patient is sweaty, you should start sweating. So elderly patients may not present with tachycardia at all for various reasons, whether this is a decrease in the physiological reserve or because they're already on medications that will stop their heart going up, the heart rate. So by all means, don't wait for the tachycardia in elderly patients to recognize that they are unwell. And massive blood loss may produce only slight or no decrease in the hematocrit and the hemoglobin concentration. So we sometimes get this from our junior surgical colleagues when they always ask in trauma situations about what's the hemoglobin doing. And actually, if you think about it, the hemoglobin is measured as milligram percent or milligram per deciliter or gram per liter. So it is a ratio of the amount of hemoglobin you have in your body in relation to the plasma volume. When you lose blood, you lose whole blood, you lose the same amount of hemoglobin and the same amount of plasma with the same ratio. So if you measure the ratio that's remaining in the body, actually it will be the same. Then the body will try to correct itself during the shock state and will not be able to produce hemoglobin, but will be able to produce some plasma, and you will start giving some fluids, and that will dilute the remaining hemoglobin. So the drop in the hemoglobin and the hematocrit will happen late in trauma, will not happen early. So do not be falsely reassured by having normal hematocrit in a shocked trauma patient. So next is investigations for shocked patients. There are some general rules here. So investigation should be guided by the suspected underlying cause. So it is all about finding the reason for the shock rather than diagnosing the shock itself. So you do an ECG for the suspected MI, you do an ultrasound or CT for your trauma patients, you do an echo or CT for your massive PE, you do septic screen for your sepsis, etc. And there are certain investigations that are generic. You will do them for all types of shock because they are important to assess the severity of shock and to monitor the response to treatment, like the full blood count, the renal functions, and more importantly, the lactate, which we'll need to focus on for a couple of slides. So talking about the lactate elevation suggests shock, but actually it is not inclusive for shock. There are so many other things that can increase your lactate level, and that is without shock. Like, for example, being on metformin in diabetic patients, or drinking alcohol, for example. So lactate doesn't always reflect tissue hypoxia. There are so many other reasons for the increase in lactate, and elevated lactate levels, generally speaking, above 4, this is associated with increased ICU admissions and mortality in sepsis, not in general. And normalizing the lactate in trauma patients and in post-cardiac arrest patients, this is a really good way to monitor response, and it is associated with improved survivability. So a bit more about lactate. Elevated lactate shouldn't actually, should be interpreted in to respond to shock and some other impending disaster. So when you see high lactate in an unwell patient, badness is happening. Do not underestimate elevated lactate in an unwell patient. This is either shock or is something else bad that is happening and you are missing. And we will come to this towards the end of the talk. So the other thing is normal lactate is not necessarily reassuring. There will be situations where you're going to face shocked patients with normal lactate. Don't be falsely reassured by this normal lactate in these situations. And lastly, having serial lactate can be very useful. What I always say to my juniors as well is, so it is like in ECGs, one ECG begets another, one lactate begets another. When you get one lactate, I would want to know what's the next reading. Is the lactate getting better? Is the lactate getting worse? An isolated number is not that useful per se. So again, some pitfalls in diagnosis of shock by lab. So labs can only suggest shock, but never exclude it. There is no single test that you can do and say, okay, test is negative, no shock. There is no such thing. A normal lactate is not necessarily reassuring because it can occur in some cases of shock. And now we're going to move on to the management part of it. So this will be my suggested approach to any undifferentiated shock. To be able to manage an undifferentiated shock, you need first to recognize it. If you do not recognize what you're dealing with, you will fail to treat. So first, recognize that you're dealing with shock. And second, support the ABCD, just like what we always do in the emergency departments. And the third step is to identify the cause to be able to treat it. So generally speaking, management of shock should be directed at treating the underlying cause and to correct the physiological derangement. Regarding the ABCD approach, it is the same like any unwell patient. We're just going to focus on few things. So with the A and B, you would always give high flow oxygen. Remember that part of the shock problem is that the tissue are not utilizing oxygen, not getting enough oxygen. Give them more oxygen if you can, and consider intubation and positive pressure ventilation, because that will dramatically reduce the work of breathing and decreases the oxygen consumption. But remember, we've just listened to Dr. Ghanem talking about intubating shocked patients. It is not that easy. It is a high-risk procedure that you need to be very careful when you do it. Regarding the circulation, 2 lines of treatment. You give fluids, whether you're going to give blood or crystalloids, depending upon the situation, and you consider vasoactive drugs. And vasoactive drugs are 2 big groups of drugs. They're either vasopressors or inotropes. The inotropes are the drugs that will increase the myocardial contractility, will act on the heart muscle to increase the contractility to improve the stroke volume, while the vasopressors are the drugs that will increase the systemic vascular resistance. These are drugs that will cause peripheral vasoconstriction to improve the blood pressure. To understand how they both work, you'll need to understand the receptors that they work on. And these are the common receptors that we need to be aware of to understand the actions of different vasoactive drugs. So we have the alpha-1 receptors, and any drug that works on the alpha-1 will get vasoconstriction as an effect. We've got the beta-1 receptor that are in the heart and in the cardiac muscles, and drugs working there on the beta-1, the result is inotropic effect. So they will increase the contractility, will improve the cardiac output, and they also have a positive chronotropic effect. So the heart rate will increase as well. Beta-2 receptors, they are in the vessels, and drugs acting on them will cause vasodilatation and bronchodilation. And lastly, the dopamine receptors in the renal vessels, and drugs acting on them will result in splanchnic and renal vasodilatation. So these are the important receptors that we'll need to be aware of to understand the different actions of vasoactive drugs. So let's talk about the inotropes. what inotropes do we commonly use in the emergency departments for shock patients? Commonest one is adrenaline. We also have the dopamine, and we have the dobutamine. These are the three common agents that we use as positive inotropic drugs in the emergency department. The adrenaline works by stimulating the alpha and beta receptors. So actually it has an inotropic action because of the effect on the beta receptors, and a vasopressor action because of the effect on the alpha receptors. The dopamine stimulates the dopamine and the alpha-1 and the beta-1 receptors. So again, it has both inotropic and vasopressor actions, and it also releases noradrenaline from the adrenergic cells. So the dopamine is a bit of a special one. It works only on the beta receptors. So it acts on beta-1 and beta-2. And the beta-1 action increases the heart rate and the force of the contraction. So it's a good inotropic drug. But the problem is the effect on the beta-2, it will cause vasodilatation. So this might drop the blood pressure. So that's why this is a very good drug to use in low cardiac output states, like the post-MI patients, for example, when the vasomotor tone is okay. So the problem is not vasodilatation, because this will not fix it. And also that's why we usually combine it with noradrenaline infusion, because the noradrenaline is a strong peripheral vasoconstrictor. So this will override the effect of the dobutamine on the peripheral vessels. So these are the important inotropic drugs that you will need to be aware of. Moving on to the vasopressors, we've got three. We've got noradrenaline, and we've got the phenylephrine, and we've got the metronidazole. The noradrenaline works on the alpha receptors, so it will cause severe peripheral vasoconstriction. That's why it's a great drug to use in hypotensive patients secondary to vasodilatation. That's why it's the drug of choice for sepsis. But the problem is excessive use of it will increase the afterload and decrease the cardiac output, because you're increasing the resistance against the heart. This will also decrease the renal blood flow and decrease the splanchnic blood flow and impair the peripheral perfusion. Regarding the phenylephrine, it stimulates the alpha-1 receptors, causing peripheral vasoconstriction. The metronidazole, I'm not sure if it is available in Saudi Arabia or not, but it is a very commonly used drug in United Kingdom. And the beauty about it is it works on the alpha receptors, causing peripheral vasoconstriction. So it supports the peripheral circulation and improves the blood pressure. But the bit about it is it can be given peripherally safely. So it's an easy drug to give, and you can give it peripherally. You don't need a central line to give it, and it works quickly. So that's why it's one of the preferred drugs to be used in UK as a positive vasopressor agent. So generally speaking, my preferred in a shocked patient, if you're not sure what's going on, is adrenaline. Get dilute adrenaline and give it peripherally. It can be given peripherally. You don't need a central line for this. And it's got positive inotropic effect, and it's got positive chronotropic effect, and it's easy and quick to prepare, and it's available in every single emergency department. So please familiarize yourself with adrenaline IV, because it is a lifesaver. Some quick pitfalls regarding management of shock. So inotropes and pressors should not be used as a substitution for adequate fluid resuscitation. If your patient is empty, there is absolutely no point trying to squeeze them. Give them fluids. So fluid resuscitation first, and then start using the inotropic drugs. So please ensure that your patient is adequately fluid resuscitated first, and then feel free to use your inotropic or pressors agents afterwards. So this was about the scientific part of the talk, which I personally think is less interesting. Let's move on to what we do every day. We see patients. So let me take you through a couple of patients that I've seen over the past few years, and let's see what you think about those ones. So this is case number 1. This was a lady who was 85 years old. She's been treated by her GP for 4 weeks because she's had shortness of breath, diagnosed by the GP as lower respiratory tract infection. Then after 4 weeks of antibiotic, the patient started going downhill and started to feel unwell. So the GP decided to ring the ambulance to refer her to the hospital for admission as sepsis secondary to a respiratory infection. So the ambulance crew took the patient from her home, and on their way to the hospital, the patient dropped her blood pressure. So they decided to change their destination rather than to go to the medical ward, to come to the emergency department resus room to be assessed and treated by the medical team as a medically expected patient. The patient arrived to resus room. I was dealing with a patient in the cubicle next to her cubicle. I've been told by the nurses, she's here. We've informed the medical registrar. He's on his way to see her. We've just cannulated her, took some bloods, and we did an ECG for her. Would you please have a look at the ECG while we're waiting for the medical registrar to come? And this was my only involvement with this case. And just having a quick look at the ECG was enough for me to know why this patient dropped her blood pressure and what's the reason for her shock now. So I'm going to give you 10 seconds to have a quick look at this ECG and to say it out loud. What's wrong here? Okay, 10 seconds is too long. I'm not doing this. Let's have a look. The abnormality here is we've got a T-wave invergence in addition to many other abnormalities, but the main ones are T-wave invergence in the inferior leads, so 2, 3, and AVF. We've also got T-wave invergence in the anterior leads, so V2 to V5. When you see simultaneous T-wave invergence in the inferior leads and anterior leads in the same time in a patient who's coming to you with this presentation, there is usually one thing that will cause that, which is acute pulmonary hypertension. And in the emergency medicine language, that will be massive pulmonary embolism. So this lady was found to have a bilateral submassive pulmonary embolism in her CTPA with right heart strain. And it was a long discussion with the respiratory team and between the respiratory team and the emergency medicine team regarding whether we thrombolize or not, but she responded well to the IV fluids. And because of her age and her other comorbidities, the decision was not to thrombolize. And actually she did really well and she survived to discharge this event. So this is our first case that we're going to talk about. So nice and easy. This is the CTPA of this lady. And as you can see, a nice, beautiful, big blood clot in her left pulmonary artery. And actually there was another one in the right pulmonary artery. This is quoted from Life in the Fast Lane, which is a really important website that I would encourage everyone to look at. So they said there that the simultaneous T-wave inversion in the inferior leads, 2, 3 AVF, and right precordial leads, V1 to V4, is the most specific finding in favor of pulmonary embolism, with reported specificity up to 99% in one study. If you do a quick literature review about pulmonary embolism in relation to the T-wave inversion, you will find loads. This is one of the articles that talked about this, talking about simultaneous T-wave inversion in anterior and inferior leads as an uncommon sign of pulmonary embolism. And if you focus here, one of the authors of this paper is the famous Amal Mattu. Here is another one talking about acute pulmonary embolism with ECG changes mimicking acute coronary syndrome. And actually they reported a case of T-wave invergence in the inferior lead and anterior leads. And they've done a literature review about this. So that's an interesting read as well to have a look at. Here's the third one coming from the American Journal of Cardiology, talking about the ECG differentiation between acute pulmonary embolism and acute coronary syndrome on the basis of negative T waves. So plenty of articles talking about this. Personally, I've seen it about 6 or 7 times, and each time it saved me. Those are patients that can easily go down the route of acute coronary syndrome while they are actually having a massive pulmonary embolism. And this was our first case. Case number 2 is, I think, more interesting. Case number 2 is by far, I would say, one of the most challenging cases I've ever had in my whole career. So that was a 39-year-old male patient presented to Southampton University Hospital Emergency Department with 1 week history of feeling just generally unwell, seen by the GP, diagnosed him as having some sort of a non-specific viral illness. And then he's had some diarrhea and vomiting for a couple of days. He walked into the department, didn't come in via an ambulance. He's had no past medical history at all. Looked unwell, to the receptionist who saw him. So she felt that, oh, something is wrong here. So she called one of the senior nurses to see the patient. And the nurse took the patient to the assessment room and took some ops. And the observations were, as you can see. So the patient was tachycardic and hypotensive. So the nurse felt really concerned and moved the patient immediately to the resus room. I was in resus that day. And what we did immediately was we've got an axis and we've taken some bloods and we've sent a sample for a venous blood gas, in addition to so many other tests, as you would imagine. The blood gas came as this. So this is the actual blood gas of this patient. And as you can see, the patient was acidotic with a pH of 7.16. The PCO2 of the patient is 7.4 kilopascals. That is 53 in millimeter mercury. So that means that the patient has got an element of respiratory acidosis. But remember that this is a venous sample, so it might not be that high in the arterial one. But the bicarb is 18.2. The base excess is -10. This patient has got definitely a metabolic acidosis here. In addition, the blood sugar of this patient, the glucose was 11.7 millimoles. So that is 200 milligram per deciliter. And look at the lactate. We've got lactate of 12 here. So seeing this was really scary to me. This is a patient who's got something bad going on that I'm not sure about yet. Looking at the gas, so few things that I spotted. We know that we've got metabolic acidosis here, because we've got low pH, we've got low bicarb and -10 base excess. We've got a blood sugar that is above 11, which is the cutoff to start thinking about DKA. So actually DKA was the first in my differential. So I've asked immediately for blood ketones, and we did the blood ketones and they were normal. So not a DKA case. Let's move on. The initial impression after DKA was that, okay, he's been having vomiting and diarrhea for 2 days. Maybe he's severely dehydrated. And to be honest, he looked dry to me. So probably he's got pre-renal failure that caused this blood gas to look like this. So I've immediately started some IV fluids, and I've given some antibiotics in case we're dealing with a possible sepsis, because things were not that clear at this point. And I started taking detailed history and doing a detailed examination. Nothing in the past medical history, no travel history, no other findings on examination, no fever. He denied any chest pain or shortness of breath or abdominal pain. So literally, I found nothing. He said that he vomited 2 to 3 times in the last 24 hours and opened bowel and had diarrhea about 3 times in the last 24 hours. And that was really weird, because this is not enough for a 39-year-old male to be dehydrated to the point of having a lactate that is that high and to have a pre-renal failure. So when I hear this, I started scratching my head thinking, I'm missing something here. So anyway, he also started complaining of lower back pain while he was with me in ED. So I've done a full spine examination and full neuro examination, thinking it might be a discitis, it might be a paraspinal abscess, and I found nothing. Everything was completely normal, not even tenderness over the spine. And this was the biggest surprise. Renal functions came back as normal, and I was like, okay, badness is there. This patient is going in the wrong direction. I am definitely missing something here. So what I did was I decided that I will repeat the blood gas after 1 liter of fluid and recheck the lactate. And that was the biggest surprise. Lactate has gone up from 12 to 14, despite the IV fluids I've given, despite the antibiotics I've given. And at this point, I was really scared. At this point, I decided that, okay, I'm completely missing it. I'm losing this patient. I've asked one of my registrars who was with me in that shift to come and have a look. He checked the patient with me. We both we've Googled all causes of high anion gap metabolic acidosis, and we've asked the patient about every single one of them. No toxicology, no history of alcohol, no nothing. We couldn't really find anything that would justify what is going on there. So my decision was 2 more tests that are still pending. I will get them, and then I will involve every other hospital member in this case. I will call all the seniors in the medical and critical care teams, because I'm losing this patient and I don't know what's going on. The 2 tests remaining were chest X-ray and an ECG. This was the chest X-ray that gave me the first clue about what was going on. So this was an AP film. So I was expecting some cardiomegaly, but to be honest, not to this extent. This was just too big for me to ignore, as in terms of the cardiomegaly, the cardiothoracic ratio. So that was the first clue. And the second clue and the final clue that gave me the answer to what's going on was in the ECG. So this was the ECG of the patient. So again, 10 seconds for you to have a quick look and see whether you can say it out loud, what is going on here. Okay, again, 10 seconds is too long. We're not going to wait. This ECG has got 3 abnormalities that if you find next to each other, you should come up with one single diagnosis. The first problem in this ECG is the voltage. This ECG is of low voltage, as you can see here. Everything is tiny, despite the normal calibration of the ECG paper. So that's the first abnormality. Second abnormality, look at the rate. This patient is running too fast. So we've got tachycardia, we've got low voltage ECG, and we've got this. Let's make it bigger. So if you look at the complexes in this ECG, they look really weird. Big complex, small, big, small, big, small, and that keeps happening. Big, small, big, small. Actually, this patient is probably in an SVT looking at this rhythm strip. So you've got a triad of low voltage ECG plus tachycardia plus what's called electrical alternans. When you see this triad, there is only one single diagnosis here, which is massive pericardial effusion. So I've taken the echo probe at this point, and I echoed this patient myself. And it was the biggest effusion I have personally measured. I've measured about 4 centimeters of big pericardial effusion in this case. So let's quickly cover the electrical alternans because it was the clue in this case. So electrical alternans is basically when you get normally conducted complexes with alternate height, as you've just seen. And it's produced by the heart is just swinging backwards and forwards within a big fluid-filled pericardium. And it is seen in about 30% of patients with cardiac tamponade. So have a look at this. This is not the patient, but if you imagine that your probe is here, your electrode is here, when the heart moves towards the electrode, then that will give you a big complex because the distance is not big and there is no effusion in the middle. When the heart moves away from the electrode, like in here, then you've got far distance and you've got fluids in between. That will give you a small complex. And the heart, as you can see, it keeps doing this. To the electrode, big complex, away from the electrode, small complex, and that keeps happening with every single beat. So that's the explanation of why we see this. So let's go back to our case and find out what happened. Few questions to think about at the moment. First question is, okay, this patient has got an SVT. Can SVT per se, can SVT alone cause electrical alternans without pericardial effusion? The answer is yes. SVT can cause what's called pseudo-electrical alternans. So you will see exactly what you've seen, the electrical alternans that we've seen, just with SVT without effusion. But SVT will not cause low voltage in the ECG, and it will not cause cardiomegaly in the chest X-ray. So yeah, so we cannot really consider this the cause in here, even, before the echo. Second important question here was, so this patient is now in a decompensated SVT. So shall we electrical cardiovert this patient? Shall we consider DC cardioversion? Because technically he's in SVT and he is hypotensive. again, that was a big question that I have asked everyone in the team, including the cardiology consultant and the emergency medicine consultant who was there. And we all agreed that this will not be a good idea. We know that the SVT is probably because of the big effusion and because of all what's going on in the heart at this point. So and we know that the patient is shocked. So actually trying to sedate to cardiovert is not going to help. What's going to help is actually getting the fluids out. So we decided not to cardiovert this decompensated SVT. And the third question was, okay, shall we do the pericardiocentesis in the emergency department, or shall we take the patient to the cath lab to have it in a more controlled environment? And our decision was, he survived a long time within the emergency department. Why don't we just push him quickly and take him to the cath lab and get it done in a more controlled environment, with a caveat that if anything happens on the way, we will just stop and do it. So we all felt that the best place for this patient to be in is the cath lab, and we decided to move. So I took the patient myself to the cath lab, transferred the patient there. On the way, the patient self-cardioverted his SVT back to sinus tachycardia, but he was getting just runs of non-sustained VT. I think I got older that day, and I've developed some extra gray hair with that patient. So successfully, we reached the cath lab. Pericardiocentesis was done there. An immediate 1 liter of hemorrhagic effusion came out, and 3 liters were drained over the next 24 hours. Interestingly, the lower back pain that the patient had in the emergency department improved to completely gone just with the fluids coming out of the pericardium. Until today, I do not have any clear explanation for this. It was a lower back pain, wasn't an upper back pain. And yeah, it just improved. So moving on, this patient had multiple investigations, including echo, CT, and MRI. He's had loads of blood tests, including HIV markers and autoimmune tests. And the outcome was he's developed cardiac sarcoma. So actually, this was my first ever interaction with cardiac cancer. He's had a cardiac myosarcoma, and he was also found to have liver, lung, and bone metastasis. And this is a very rare condition. You can see the incident here, how low the incident is. Remember, we're dealing with a 39-year-old male, normally fit and well, not on any regular medicine, no previous past medical history, and 2 young kids at home. The life expectancy with this tumor, when it reaches that far, is a maximum of 6 months. So this patient, I failed to follow up to find out what happened later to him. And to be honest with you, I intentionally tried not to follow up anymore because I didn't want to know what happens. But thinking about it now, I think this presentation was really confusing and challenging to diagnose. There was no clues anywhere in the history that I could use to expect that I'm going to end up sticking a needle into this patient's chest. And this case was also very challenging to treat from the ED point of view because of all the complexities associated with the arrhythmias. So he's been in SVT, he's been in non-sustained VTs, and that was all because of the pericardial effusion and the myocardial tumor that was causing all these myocardial irritability. And also because pericardiocentesis is not a procedure that we see or do that frequent in the emergency department. So when it happens, when you need it, you're not going to find yourself skilled enough to do it because you don't do it that frequently. So it was a very challenging case that I wanted to share with you, just to give you an idea about how shock can sometimes be tricky when they present. So this is my learning points from this talk. I think shock is a very common presentation in ED that you must know about, and it can sometimes be really hard to diagnose and treat. And shocked patients with impaired cardiac output, they usually present with cold peripheries. So please spend some time feeling the peripheries of the patients. And shocked patients with impaired systemic vascular resistance can present with warm peripheries. So relying solely on systolic blood pressure is an indicator for shock can delay your recognition of shock and can mislead you. So please use the shock index as a more sensitive parameter to diagnose occult shock. And remember that lactate elevation suggests shock, but this is, it has a big differential diagnosis. It is not just shock. And remember that normal lactate is not necessarily reassuring. Don't forget that management of shock should be directed to treating the underlying cause and correction of the physiological derangement. And remember that inotropes and vasopressors should not be used as a substitution for adequate fluid resuscitation. And lastly, I'm a little bit biased because I like ECGs, but I think the answer is always in the ECG. We just underestimate the ECGs, and that's been proven in the last two cases that I've shown you. And this is it for me talking, and I'm now open for your questions. Thank you very much.
Thank you, Dr. Hesham, for this valuable and very informative lecture in a very challenging point. I don't see any questions. It's clear and to the point. There is one question now. Still shock index dependable in old patient or whom on beta blocker?
So I would say this is, sorry, any more?
Yes, go on.
Yeah, so I would say, of course, anything is dependent on the situation, and in elderly patients, they have less physiological reserves. Their ability to produce tachycardia is less, and they're usually on medicine, usually beta blockers, that will stop their heart going up. So I would say it will not be that useful in these ones. So you will need always to use your tools in the right context. And I would say just using the shock index in isolation in these cohort of patients will mislead you as well. But thanks for the question. It's a good one.
Thank you, Dr. Hesham. Thank you.